Lincolnshire's a large county geographically, and we had a significant number of people who were attending A&E when that wasn't necessarily the best thing for them to be doing. There was a national project where care homes could dial *6 as part of the 111 programme and be put through to a different kind of support. We needed a different technological route which didn't work, and somebody had the bright idea of, instead of dialing 111 and *6, why not just give out the number? So the care homes now have a number to call when something is urgent but not life-threatening, out of hours, and they dial the clinical assessment service. Someone rings them back and gives them advice, and it's an expert in the locality. It's someone who they may well have spoken to before, and it just seems to give the direct support service which works. We initially set up with just using nursing homes because we felt that that was one of the key areas of need, and also the easiest place to avoid any patient safety pitfalls. And the nursing homes were given equipment to take basic obs if they didn't have it, and an agreed way of recording the situation that they were seeking advice about. The feedback from the nursing homes has been fabulous. They can now wait and observe a resident, knowing that if something happens or they need advice, they can get it straight away. And particularly some of our less experienced nurses will sometimes use the CAS service to get a more senior clinical input, just to ratify their decision or to help them when something is going in a different way than the way that they were expecting.
Certainly in the initial 3-month pilot that we did for CAS for care homes, what we found was that there was a 41% reduction in A&E admissions for the care homes who were taking part in the pilot, and there was a 27% reduction in acute hospital admissions. So as a result of that, it was decided that we would continue the service, and certainly during the winter period that we're just emerging from, we did actually extend it to try and include care homes who had particularly high levels of contact with urgent and emergency care. What we know is that a lot of care home residents will tend to trigger an emergency response simply because their health, even on a good day, is not particularly good. And I think that what staff now have is the confidence of knowing that they can talk to one of us in the CAS. It can be an ongoing process, so it's not unusual for one of us to talk to somebody in a care home, give some advice, and then say, call us back in a couple of hours and let us know how you're doing. We joined together with a number of other services, including the ambulance service, hospital services, adult social care commissioners, and Lincolnshire, to look at how we could actually develop our own high-level senior clinician assessment service that would still take the calls from 111, but that would provide the clinical assessment. And over the 3 years, that's what we've done. We've done it very carefully. We've done it step by step. So we have slowly increased the types of calls that we receive into the CAS.
This is where the CAS for Care home calls come in, where my service advisors will take those calls, speak to the care homes, get some information from them, put all that information onto the electronic system that then goes through to our CAS clinicians, who take those calls off a CAS stack, and they will ring the care home back and then proceed from there as to what's in the best interest of the patient. So before this project was put in place, I think the care homes were quite frustrated in terms of being able to get through to a service quickly. The fact that they now have a dedicated line, they certainly knowing the voices of my staff on the end of the line, so therefore they're building up a rapport. Those messages are coming through quickly and being dealt with very quickly, which I think they're finding is really useful. A lot of our CAS clinicians equally have been part of the home visiting team, so they may well have actually met a lot of these individuals in the care home. So again, it's putting faces to names and names to voices that is certainly building as the time goes on.
Okay, how can I help today? I believe that you're concerned that David's got a chest infection?
Chest infection.
Okay, fantastic.
Kind of using his ribs, are they being sucked in as he breathes?
Ribs sucked in? No, not really, no.
Okay, what's his colour like in his face? Is his normal colour?
Colour normal.
And what's he coughing up off his chest?
Phlegm,
Okay. All right. Is there any blood in that?
no blood in now.
Okay. Is he complaining of any sore throat?
Not complaining of sore throat,
Does he have a fever?
no fever.
Okay. Okay. Any complaints of pain in his chest?
He hasn't complained of any chest pains at the moment.
Any increased confusion?
No confusion.
Okay. Is he diabetic at all?
No.
Okay. Have you got any observations there? Kind of temperature, saturation, pulse?
CAS is a really great support system for our staff, for our nurses. So if they want a second opinion or they need some urgent advice, they can get straight through to a clinician. Sometimes on an evening, they're the only nurse on duty, so they're getting straight through. It might be that they just need some guidance, where should they go next. We have 60 clients, we're a new build, and we work in small houses, so we deal with clients who have got residential needs or general nursing needs, dementia needs, and clients who have got behaviours that challenge. We're trying to prevent hospital admissions, so is that a clinician can come and visit the home, give a second opinion or escalate the situation if needed. We've had things like supported with antibiotic prescriptions, so we don't have to wait, particularly over the weekend. We're not waiting 48 hours for a GP. We can start that, and that's preventing hospital admissions.
The care homes that have used the service give excellent feedback. Particularly for a nursing home where there's one nurse, maybe with some assistants on duty overnight, it can be quite a lonely place to be when you have a resident who is clearly very unwell. There are significant numbers of people who in the past would have gone in the back of an ambulance in the middle of the night to what can be a very scary A&E department, and they can now stay in their own bed and they can still receive the medical treatment that they need. So it's been a fabulous service from our point of view. We just hope it continues and grows.